So over the next 20, 25 minutes, I'll try to take you through to some of the newer advances in the management of lower risk MDS. And it is definitely an exciting time to be there. As a person who's significantly interested in clinical trials, this is a time for us to understand this disease from the therapy. So we all know with the IPSS are primarily the main tools we use for establishing the risk categorization of this disease. We know that very low risk MDSs with a median overall survival of 9 years and 5.3 years, and respectively, and also the intermediate one risk MDS with a median survival of 3 years is generally classified as a low risk MDS, and predominantly 2/3 of the patients belonging to this low risk category by R. And when you look at the survival of these three categories of lower risk MDS, these patients do suffer a significant loss of their life with compared to a general population. And in the context of intermediate risk MDS, the life year lost is close to 12 years. So although we call them as lower risk MDS, it is necessarily not that pleasing for the patients because it's technically not low risk disease at all. So when we come to that context of defining low risk MDS, what do mutations have in the context of defining low risk MDS? So we know that we can't sit with any talk of MDS without going through what we understand about the genomic makeup of these diseases. And historically, nearly 10, 15 years back, these were the gene mutations which were linked up to MDS, but they were not just exclusive to MDS, as you see these gene mutations in a number of other diseases as well. But we know with the plethora of genomic abnormalities described in myelodysplastic syndrome, this has expanded significantly, predominantly understanding the pathobiology and the pathophysiology of the disease, not yet significantly translated into therapeutic advances. So how do we define low risk MDS? Because I have to establish that before we go into therapeutic aspects in the context of low risk MDS or lower risk MDS. So I talked about using the RIPSS. Where do somatic mutations have a role to play in? And also, how do we define? So if you use IPSS R, this is how potentially you might define somebody as having low risk MDS in the context of using a somatic mutations. But we also know that we need to look at red flags in the so-called defined group of patients with lower risk MDS. And some of them are illustrated there, i.e. if they have a rapid decline in their platelets, refractory or progressing on therapy, or fibrosis, or worsening cytopenia, if it's not therapy related, and also cytogenetic evolution, then we would think that these patients have got some high risk features in the low risk. And the intermediate category of MDS in the prognostic classification always creates trouble, because what if we have an intermediate risk IPSS with high risk somatic mutations? Would you count one as high risk? Would you have two? Or what if you have a patient who does not have a high risk somatic mutation? Which is why I think the IWG molecular working group put together this proposal for an IPSS or molecular subclassification of MDS. And this was presented in last ASH by Dr. Elsa Bernard, looking at number of patients, close to 3,000 odd, to stratify these group of patients. And interestingly, a third of patients had disease-modifying agents. And when they looked at 152 gene sets with a VAF more than 2%, they were able to identify mutations in up to 94% of patients having one oncogenic mutation. Or if you put it the other way, 6% of patients did not have any genomic abnormalities in this 152 mutations. And as you could see, patients with mutations had at least 4 mutations per patient. And the models were used. Mutations were binary, i.e. you have a mutation or you don't have a mutation. and they used 16 main genes which came into the first categorization for risk evaluation, and an additional 15 genes for what they called it as residual risk evaluation. So number of mutations was also important, but not the variant allele, if you can see, or the gene-gene interactions in this group of patients as well. So they looked at leukemia-free survival, overall survival, and also AML transformation in this group of patients, and was adjusted. And these were the three top genes which came into the prognostic model. Not surprisingly, P53, MLL-PTD, surprisingly, although rare, and also FLT3, which we know is rare in the context of MDS. So what they came up was this weighted sum of prognostic variables, resulting in a continuous index. The advantage of this is that you can have a patient, you can score them into this and to see where they land up with an average hypothetical patient being at 0, and a 1 unit increase means you double the risk. 1 unit decrease means you halve the risk of both overall survival and leukemia-free survival. And what I thought pertinent to this talk I'll take out is that, remember I told you lower risk MDS contribute to 77% of patients by IPSS-R. But if you use this classification, it comes to around 55% that they are low risk, which is very low, low, moderate, low in the context of IPSS molecular subclassification, with even this group of patients having a median overall survival of 4 years and leukemia-free survival as well. So again, saying that if you use genomic classification here, you get number of patients who get re-stratified. Most patients get upstage rather than downstage from a low risk to a higher risk, and indicating that are we going to increase the group of patients who have low risk MDS rather than decrease the group of patients who have low risk MDS, indicating that these IPSS-M indicates a personalized, reproducible, and interpretable calculation. So the reason for showing this data, which is slightly peripheral to the talk, but it's important to understand that these are group of patients with the genomic knowledge, whether these patients have a increased or a decreased risk both in survival and leukemia-free survival as well. So how do you manage this group of lower risk MDS patients? So the therapeutic goals in lower risk MDS still more or less remains the same, that you do have a monitoring plan in place, and this always comes into discussion, and we'll have a chat about it. How often would you repeat a bone marrow? Is there any role in repeating the genomics, in particular cytogenetics, an additional thing? How would you alleviate the risk of transfusions? You'd always want to look out for other contributing factors for transfusions. And the important thing is we are looking at quality of life for these patients and decreasing the risk of transformation for acute myeloid leukemia. And we always say that this is an expectant manifestation management, but the question always patients ask is, when you tell them you're on a watch and wait strategy, we want to do anything, patients always come back to you and say, what are you watching? What are you waiting for? Because you say this patient has got a pre-leukemia or a cancer, and you say we won't do anything. So that doesn't translate into a patient saying that doesn't work properly for me. So what are the therapeutic options? I've put in the FDA and EMA approved therapies. And as you could see, very busy in 2020-21, which is very encouraging to notice in the context of people treating MDS, because this, I always hear this whenever other colleagues say, why do you treat MDS? It's very depressing because you do not have therapeutic options, and you should be an eternal optimist to treat these conditions. And I think I am an eternal optimist, because I think we will translate some of the biological knowledge into therapeutic advances as well. But mostly in high risk MDS, there has been a few FDA breakthrough therapies approved, but in UK, we are significantly lagging behind in approved therapies, and which we'll touch upon here as well. So how do you manage a low risk MDS? And we define this low risk MDS. And I would still say, even in this day and age with advancing therapeutics, we need to be discussing with patients about potential of transplantation if they're eligible for transplant, even for a low risk MDS, not necessarily to subject them to transplant, but something we need to always discuss about it. Non-transplant options, which very, very important, and supportive care, we know is the stay of the treatment, because we know that quality of life in patients with low risk MDS compared to patients with normal population is significantly different. When you look at different domains like mobility, self-care, ability, their usual activities are affected, and also anxiety and depression, not surprisingly as well. So how would you do supportive care? We know that individualized hemoglobin threshold are based upon survey data. So there was a very good study done in UK with other groups by Professor Simon Stanworth looking at liberal versus restrictive strategy. And not surprisingly, the liberal strategy was found to be better, i.e. higher hemoglobin thresholds with transfusions was better than lower thresholds. We still use GCSF in the context of recurrent infections or to aid delivery of treatments as well. And also we use supportive measures for bleeding. TPO receptor agonists are not approved in the context in at least in UK, but there are off-label use of it. And there was a couple of studies, one from NIH and the other from the Italian group, of using TPO receptor agonist in the context of low risk MDS. And patients should be considered for iron chelation therapy once they reach a certain ferritin threshold or transfusions. So when you look at what other things can you do, EPO has always formed the backbone of treatment for our group of patients. We still use the Nordic score, which is nearly 20 years old, to look at the predictability of response with scores with essentially transfusion independent and low EPO having a better predictive chance of response. Number of agents, we need to use it for 24 weeks before saying this patient, is it working or not working for this group of patients. Various EPO combinations can be, erythropoietin stimulating agents can be used, lower dose, higher dose with the addition of GCSF in a proportion. So I would usually use it lower dose for 8 weeks, maximum dose for another 8 weeks, and then add in GCSF for the next 8 weeks. There are various other scoring systems which have come about, which are slight refinement of the Nordic classification, but I still use the Nordic group. So there is a Canadian scoring system which used a EPO cutoff of less than 100. There was an ITACA, which was the Italian and the Canadian collaboration. There is also predictive score using the IPSS-R to see whether somebody would benefit from a erythropoietin stimulating agent or not. Practices significantly vary. This is just a snapshot of a study done in Europe, showing that in patients with MDS who have symptomatic anemia and a hemoglobin less than 10, only a proportion of patients were treated with ESAs, up to 50%. And even those patients, only about half, most 2/3 of them were treated when their hemoglobin was less than 10 at the time of start of EPO. And as you could see, half of the patients had already received blood transfusion prior to starting erythropoietin. Why is that important? Because time to first transfusion seems to have an impact on the survival. And not only that, patients who are not transfused and having EPO in this green line do particularly better than, not surprisingly, patients who were transfused and were not treated with EPO, indicating that you have to treat these patients at an earlier time point rather than leave them too late for the treatment to kick in. And it's also patients who fail EPO at an earlier time point have a poor survival, around 40 months, compared to patients who fail at a later time point. And as you probably know, EPO works on an average for about 18 months to 24 months. So what other therapeutic options do we have other than EPO and best supportive care? We know lenalidomide in the context of Delphi-Q, which we know is only about 2 to 3% of patients with MDS. Various trials were done over a period of time, essentially showing that up to 50 to 60% of patients, or up to 70% of patients, could have a hematological response in the context of DELF-IQ, median response lasting for a period of 2 to 2.5 years, and half of the patients achieving cytogenetic response as well. And obviously, lenalidomide has been tried in non-DELF-IQ as well. And this is the data, randomized controlled trial data, showing that around 20% of patients will have a transfusion independency for a period of 6 months, while 1/3 of patients will be having a transfusion independence for a period of 8 weeks. And this was a trial published by Alan List, looking at this ECOG 290Y study, which was presented in ASH a couple of years, again showing there was some role in the use of lenalidomide and EPO in patients who were refractory to erythropoietin, but the group of patients who respond is going to be very, very low as well. But this was a very large study of around 200 odd patients done in this trial. So what about other therapeutic options? We talked about lenalidomide, but there is a group of patients who would benefit from ATG and cyclosporin, or ATG or cyclosporin, predominantly hypocellular marrow. But as I mentioned to you before, a transplant should be considered not only at the time of their diagnosis, but during the course of their disease as well, when they develop these features, either refractoriness, worsening cytopenia without progression, and fibrosis and other features as well. But what we're trying to deal with in the context of MDS is predominantly around the ineffective erythropoiesis. And I've shown a number of factors which might impede this erythropoiesis, and how we can use drugs or agents to modulate this, either therapeutically using measures, drugs, or using other agents around inflammation. Because as you probably know, about 30% of patients with low risk MDS will have an associated immune dysregulation or hyperinflammation or autoinflammation as well, and whether that could be modulated with different agents. And one of the first drugs I'm going to talk about in the next 5 to 10 minutes is luspatercept. As we know, this is an activin ligand trap inhibitor, which is important, i.e. the GDF11 and the activin. These molecules are important in controlling the late stage of erythropoiesis, which is EPO independent, so indicating that these agents are erythroid maturation agents, and these has been trialed in the context of beta thalassemia as well. And there are 2 compounds, one is luspatercept and the other one is sotatercept, and there are other agents like agents in development, which seems to work even in the early stage of erythropoiesis as well, which I'll touch upon in the next few slides. So essentially showing that there are these agents work in the late stage of erythropoiesis. These are erythroid maturation agents. These are given subcutaneously every 3 weekly, and as shown in the pivotal trial, which was a plenary abstract in ASH and then subsequently published in NEJM now nearly a couple of years back, showing that 38% of patients had a transfusion independence for a period of 8 weeks. But if you look at 3-month transfusion independence, it was around 33%. And even in patients who were not transfusion independent for that period, there were blocks of 8 weeks of transfusion independence seen in around 50% of patients as well. Again, indicating that this is an agent can be used predominantly in patients who have ring sideroblasts, but I'll touch upon other study in non-ring sideroblastic anemia as well, showing that this is a very well tolerated and trial as well. So this trial is ongoing, looking at comparing EPO versus luspatercept is a first-line treatment in MDS. Obviously, the recruitment is going slow as well. What other agents are there in clinical trials? So this is the data from this drug called imetelstat, which is a telomerase inhibitor, which is used in slightly other diseases as well, but has been shown to, in the phase 2 trial, to induce transfusion independence in this heavy heavily transfusion dependent patients in around 35% of patients as well. But if you look in the patient of non-Delphi-Q and HMA naive patients, the response rate was close to 40 to 45%. This is looking at a slightly reversed waterfall plot with the longest transfusion-free dependency. And this drug is given IV every 4 weekly and has been associated with transfusion independence. The phase 3 data from Geron has now, the phase 3 trial has just stopped recruiting a couple of months back, and hopefully we should have some readouts. I'm hoping by end of the year in ASH or early next year. And this drug definitely induces cytopenia, predominantly thrombocytopenia and neutropenia, but it's reversible as well. So indicating that there are agents in this as well. And I showed you that data as well. Azacitidine, does it work in low risk MDS? In US, it can be used, but in Europe and other places, it can't be. It's not licensed because there are some studies which showing that not much response, but maybe in about 10 to 20% of patients, but responses do not last as well. Aza plus EPO as well, not been shown to be particularly effective in lower risk MDS. But what about oral azacitidine? So this data was published in JCO less than a year back, looking at oral azacitidine in transfusion-dependent MDS with associated thrombocytopenia as well. When the trial was designed, there was various reasons why this was done, but the patients had to have a platelet count initially less than 50, but subsequently amendment said it can be less than 75. Comparing it with placebo, the dose used was 300 milligram every 21 days. This is slightly different to the doses used in the Quasar AML study, and looking at transfusion independency as well. So, and not surprisingly, around 30% of patients were transfusion independent for 2 months, around 28% for transfusion independent for close to 3 months, slightly higher rate in placebo as well, and the median cycles was 5 and 6. There was no difference in the overall survival, but unfortunately, numerically, there was an increased number of deaths in the oral AZA arm, but that is possibly related potentially to these patients being higher risk, low risk MDS with neutropenia and thrombocytopenia as well. And most of these patients had a platelet count very low as well. This is a fantastic compound and a fascinating drug as well. This is a combination of oral decitabine with cediseridine, which is a cytidine deaminase inhibitor. As we all know, the hypomethylating agents it's not bioavailable orally. That's because this enzyme called cytidine deaminase is produced in the gut and the liver. And if you use a cytidine deaminase inhibitor, you're able to deliver the hypomethylating agents. This has been FDA approved in US, and there are ongoing trials both in high risk and lower risk MDS as well. This is another fascinating molecule which is undergoing phase 2, phase 3 study, which is called roxadustat, which is a HIF-1 alpha inhibitor in patients with lower risk MDS who are low transfusion dependent. Early data showed that around 30% of patients again had a transfusion independency. There are a number of agents which can be used depending upon countries and approval as well, but not shown significant responses in the context of clinical trials. But it's very, very interesting that these compounds are going through a number of development phases. So this is an algorithm which I've taken away from the US, which is obviously slightly different because they're able to use hypomethylating agents and also lenalidomide in low-risk MDS if they fail other therapeutic measures as well. And luspatercept is also approved. And this is a summary of what I've talked about. I've not talked about a few other agents which are going through clinical trials, targeting different pathways, pyruvate kinase, dihydroorotate as well, and whether those drugs will have a role to play as well. But in the last few minutes, just going to talk you through a few of the options we are doing in UK as a trials community. And the things I at least learned from COVID, I know we learned a lot from COVID, but what do we learn which we can translate? And one of them is the role of repurposed drugs and ability to design innovative platform trials as well. And one of the things we've designed using this trial called Repair MDS of using repurposed drug to improve hematological response. The drugs used does not matter as such, but its ability to repurpose and use drugs in medicine. This is again an arm of comparing danazol, which is not surprising, with another combination of a cholesterol lowering drug, a steroid, and an anti-epileptic, due to some biological data which was generated by the UK group of using this. So again, showing that you can use repurposed drug as well. One of the other things which we are planning as a community in UK is to do early intervention before the onset of anemia in MDS. When you have mild anemia and symptomatic, how can you intervene? How can you treat this group of patients? And one of the designs we are doing is doing a 3-arm comparison between luspatercept, EPO, and standard of care, and stratifying them based upon whether they have MDS. And we're also using anemia of the elderly and CCUS anemia related domain. Just to give a flavor as well, if you're symptomatic, transfusion independent, you come into the study, they're randomized either to active monitoring or EPO or to luspatercept. They have a good response, we leave them alone. If they progress, they go into out of the trial, but into other trials within the platform design. But if they have a stable disease, we have a number of randomizations to compare them with different treatments as well. And to conclude, what I will say is that we are definitely understanding the biology of the disease, not just low risk MDS, but high risk MDS. And as I said, MDS is one disease which we have learned a lot on the pathophysiology of the disease, but not yet translated into therapeutic options. But the question is, with the onset of these new drugs and trials, are we able to abolish and dampen down the transfusion dependency using drugs which are promising? Or are we going to shift the paradigm, and are we going to treat these patients before the onset of transfusions? And the last 2 slides is mainly around the focus we have in the UK while we are trying to design patient-focused trials rather than authorization or regulatory agency-based trials, and to ability to innovate, modify as well during the trial design. And the whole goal is, can patients have access to different therapies during the course of their disease, so that they do not feel left out as well. So I think with that, I'll stop. I'm happy to take questions in the live sessions. Hope you have a fantastic rest of the conference. Thank you.